Welcome to the OGSM webinar series. Today is the turn of the urogynecology to present something that is common, which is overactive bladder. I am Dr. Ng Po Yin. I'm a consultant urogynecologist with Kuala Lumpur Women and Children Hospital, now known as Hospital Tengku Aziza. So when I first started to start urogynecology back in 2006, I don't see much of overactive bladder because most of the patients do not know about this disease and they think it's a part of aging. So, but as time passed, we have a lot of seminars, a lot of workshops for the doctors and the patients. More and more patients start coming to us with overactive bladder syndromes. And I still think we're still at the tip of the icebergs, and there are many more patients out there who actually have overactive bladder. So without further ado, there are a few housekeeping I would like to tell you about. That is that if you have any question, please go to the Q&A and ask your question. So today we've invited 3 speakers from Malaysia, our own local speakers. They're all very expert in handling overactive bladder. And all of them have seen a lot of patients with overactive bladder. So our speaker will talk to you on basics of overactive bladder, what are the treatment available, and introducing a new drug, which is a different group altogether. And and also we'll touch a little bit on the irretractable overactive bladder, what are the options available. Speaker will be talking about the new drug that's available and difficult overactive bladder. I want to introduce a good friend of mine. He is Mr. Warren Nu Hua Lund. He's a consultant urologist whose main area of practice covers a broad range of urological issues, including urinary stones, urinary tract cancers, and recurrent UTI. He subspecialized in female urological matters such as overactive bladder and urinary incontinence, as well as men's health, which include erectile dysfunction and prostate disease. He performs urological implant surgeries such as sling, artificial urinary sphincters for patients with urinary incontinence, and penile implants for patients with erectile dysfunction. He also performs various oncological procedures, and he conducts various reconstructive procedures for patients, both adult and pediatric, with bladder dysfunction. And he had delivered the largest series of Botox injection in patients with overactive bladder in Malaysia, and is the only urologist in Southeast Asia which performs sacral neuromodulation procedure for bladder dysfunction and artificial urinary sphincters for female with severe urine leak. He underwent subspecialty training in neuroreconstructive urology and female urology in United Kingdom at the Queen Elizabeth University Hospital, Glasgow, and had a fellowship in attachment in functional urology at University Hospital California Davis in California, United States. He is trained and Europe certified robotic surgery, specializing in various complicated robotic surgery and prostate and kidney cancer. He obtained his fellowship training in robotic uro-oncology at Peter MacCallum Cancer Center in Melbourne and Guy's Hospital and St. Thomas Hospital, London. He's also trained in Paris in robotic functional urology. And Dr. Loh is also a recipient of the prestigious Tun Sophia Foundation Scholarship, which supported his robotic training at Guy Hospital in London. He has delivered various oral and poster presentations, both locally and internationally, and has published research papers in domestic and international journals. He had chaired various neuro-urology and uro-oncology symposiums across Asia Pacific and is a regular speaker at European and American urological conferences. He's currently the principal investigator in a few international multi-center trials and takes part in health awareness program and workshop in Malaysia, Indonesia, Vietnam, Korea, and Australia. He's also the examiner for the Malaysian Urological Board examination and an adjunct professor for University Sarawak, Malaysia. So I pass the session to Dr. Loh.
All right. Good evening, ladies and gentlemen. I'm honored to be invited to give a talk on the topic, which is the role of pharmacological treatment in women with overactive bladder. So now a little bit about the definition. Overactive bladder is defined by the ICS as urgency with or without urge incontinence, usually with frequency and nocturia, in the absence of pathologic or metabolic conditions that may explain the symptoms. So as you know, we usually will classify it into storage and voiding symptoms. They are all under the lower urinary tract symptoms. As you see, the storage symptoms includes frequency, nocturia, urge incontinence, and other incontinence, whereas the voiding symptoms includes the intermittency, slow straining, hesitancy, and of course we have another element which is post-void prevoid and post-void feeling of incomplete emptying of the bladder. So you can see from these slides that OAB essentially is a storage symptoms. Now, you know that my topic, I'm talking about women. So storage symptoms are not sex-specific, but it's also increased in an age-related fashion and are prevalent in both male and female patients. Now, since we're talking about women, we need to know the prevalence. So OAB in a population-based studies, the rate range from about 7% to 27% in men, and in women is higher, which is 9 to 43%. And since OAB is a symptom-based diagnosis, the quality of life impact symptom is the critical aspect of this condition. So now, looking at the global prevalence of the lower urinary tract symptoms, you can see that in year 2008 and 2018, basically they are almost the same. And the next slides, you can see that for adults more than 20 years old, women actually have a higher prevalence rate as compared to men. And of course, in Asia, we get very similar results as well. Women a little bit higher than men, and the prevalence is about 10%. So from this, you know that overactive bladder is a highly prevalent disease worldwide, and it increases with age, and rates are higher in women than men, and the prevalence vary considerably by region. And urinary incontinence is the most severe form of OAB, and mirrors its epidemiology. And we know that OAB is associated with considerable economic costs. Just imagine that you have to buy the diapers, and it will be an impact to the caregiver as well. OAB adversely impacts numerous quality of life measures, and the more bothersome the symptoms, the greater the impact on quality of life. After all, incontinence or OAB is basically a symptom complex. Now, after assessment has been performed, sometimes we must accept that if you don't do anything about it, it's actually perfectly acceptable, because otherwise, we are not trying to drive patients into taking medication, doing surgery and all this. If the patients are able to live with themselves, a little bit of a bothersome overactive bladder or even incontinence is perfectly fine. Now, since I'm going to talk about the pharmacology treatment, and I believe Dr. Ida before me has spoken about the antimuscarinic, I'm going to focus mainly on marobagram, which is a beta-3 agonist. As you know, beta-3 agonist essentially is a medication that relaxes the detrusor muscle by actually acting on the noradrenergic receptors. So what it does is that it causes relaxation of the bladder. Okay. Now, the pathophysiology behind is that we know that we have these afferent nerve fibers, which is found in the urothelium and the suburothelial space. So all these fibers are basically taking part in the process of bladder function. Now, if there are imbalances or disturbances in this suburothelial complex, the abnormalities of the central function and also the nerve conduction signals will all be impaired, and this will lead to overactive bladder. So to date, there are 3 theories that contribute to the genesis of an overactive bladder. Essentially, is the urothelium-based hypothesis, the myogenic hypothesis, and the neurogenic hypothesis. Now, we also found that OAB basically is quite prevalent in elderly people. The reason is because they are partly denervated. Now, studies have shown that in elderly people, they actually have a smaller bladder capacity and also increased non-voiding contraction of the detrusor. So you will ask me one question, the elderly people, since you said that the detrusor is partially denervated, how can they be generating overactive bladder? The answer is yes. The truth is that even in those patients who actually have their bladder taken off And especially for urologists, we do a lot of autonomic neurobladder. Even with that, you just need to have a little bit of a suburothelial nerve complexes running around that particular organ. You will have a lot of disturbance in terms of the nerve signal transmissions, and ultimately that will lead to non-voiding contractions of the bladder. And of course, in elderly people, arteriosclerosis induced chronic ischemia also leads to fibrosis, smooth muscle atrophy, non-compliance, and all these things leads to small bladder with a lot of overactivity problem. Now, how do we diagnose apart from history? Obviously, you need to do things like, for example, an ultrasound to find out whether there's any other pathology, for example, bladder cancer, okay? And on top of that, since we have bladder cancer which are quite flat, now cystoscopy is very important, not just to rule out the bladder cancer, to find out whether there's any obstructive cause, for example, a urethral stricture or even a bladder stone that could potentially narrow down the passage and leads to overactive bladder. In men, a classic example would be prostate. Urodynamic is very important because we know everybody may present with some form of an overactive bladder-like symptoms, but sometimes whatever that the patient present may be quite different from what the patient has. So in order to find out what the patient has, we have this urodynamic or bladder function study or bladder pressure studies that will actually identify different types of bladder dysfunction. Now, some patients' additional measures may be required, okay? So apart from urodynamic, we may actually need MRI of the pelvis to find out whether there are any other associated pathology. So this is just some image to show the cystoscopy as well as an ultrasound to find out whether there are any causes. And of course, I guess everybody here is very familiar with urodynamic. That's how we interpret the urodynamics with the tracing. Now, first line treatment is always behavioral therapy. So we will tell the patients to go for bladder training, biofeedback, physiotherapy, pelvic floor exercise, Kegel exercise, to modify their lifestyle and see whether it helps. Now, if it doesn't help, the second treatment would be antimuscarinic or even a beta-3 agonist. So I'm not going to elaborate anything on the antimuscarinic because I believe Dr. Ida before me has spoken a lot about this, totorudin, oxybutynin, trospium, solifenacin, darafenacin, and oxybutynin. So what I'm going to talk about is mirabegron. Now, Vibragron is another one, but it's currently not available. It's probably better because it's short-acting, but we are still waiting for it to be, of course, marketed in Malaysia. So at this moment, we're just going to talk about the mirabegron. So I've elaborated a little bit about the mechanism of action, which essentially is to stimulate the noradrenergic pathway, and that leads to the bladder relaxation. So, in order to support what I said, I need to actually produce the paper. And then, of course, you have this randomized European Australian phase 3 trial, which essentially is a Scopio study, where they take all those patients, men and women above 18 years old, in a span of about 3 months, with the primary objective of studying the incontinence episode as well as maturation episodes within 24 hours. And since this is a 3-month studies, they use 3 different randomized arms, which is placebo, totorudin, as well as mirabegron. And in this studies, we use only about 50 milligrams. And of course, in this studies, it shows that there's a significant reduction in incontinence episode in the arm of mirabegron, which is 50 milligrams. Now, for the other endpoint, which is reduction in the maturation frequency, as you can see from this chart, that the mirabegron 50 milligrams actually do much better as compared to totorudin. Okay. Now, what we are most interested in is basically the side effect. As you know, we're talking about beta-3 agonist, which is mirabegron. The one that is really of an interest to us is the hypertension. So you can see from the studies here, compared to placebo and also totorudin, you can see that mirabegron actually doesn't have an increased percentage of hypertensive side effects. That is, of course, measured from here is a treatment emergent adverse events in the studies. But dry mouth is significantly lower in those patients who are actually taking the mirabegron as compared to totorudin and also the placebo. Now, in conclusion, mirabegron 50 milligrams over a span of 3 months demonstrated superior efficacy compared to placebo, and the primary endpoints, which is the reduction in maturation and also the incontinence episode over 24 hours, is actually shown very, very clearly over here. So it is not just effective for treatment-naive patients, means patients have never been treated with any medication before, but it's also effective for those patients who have been given antimuscarinic and it doesn't work very well. Okay, so generally it is actually well tolerated. So this study supports the efficacy of mirabegron in the treatment of OAB patient. Now, coming to the next slides, you know that this Skopje study is only a study over a span of 3 months. Now, what about a study which is over a span of 12 months? You need to know whether, you know, in a longer term, for example, a year, whether the effect of mirabegron is sustainable, whether there's any more reported side effect or not. So that's why we have these TORUS studies. TORUS studies basically is randomized into 3 arms. One is mirabegron 50 milligrams, one is 100 milligrams, and one is toturidine 4 milligrams. And in Malaysia, at this moment of time, we don't have mirabegron 100 milligrams. But these studies is good enough to show there's a significant reduction in incontinence episode, you know, stretching over 12 months, okay, for mirabegron. And likewise, even for maturation frequency, it shows a sustainable reduction in the maturation episodes over 24 hours. Now, coming to the mean volume voided, you can see that mirabegron 100 milligrams definitely allowed the patient to pass more urine as compared to 50 milligrams mirabegron and 4 milligrams toturidine. So in conclusion, TORUS studies basically is a studies studying the mirabegron 50 milligrams and 100 milligrams daily over 12 months is well tolerated, okay? And then it actually shows improvement in the symptoms of urinary incontinence, frequency, urgency, all right? And also it supports the long-term safety and tolerability of the mirabegron in the treatment of overactive bladder. What we are most interested in is the reported side effect. So you can see that these studies also again study the side effect, and you can see very clearly that hypertension from here, mirabegron 50 milligrams is about 75, 100 milligrams about 80, and toturidine is about 78. So it's actually not any worse as compared to, in general, any other anti-muscarinic. And of course, the one which is really striking is actually the dry mouth. You can see from here, dry mouth is significantly lower in mirabegron as compared to toturidine. But the other one which is of interest is constipation. Constipation is almost the same across the board. And of course, we have other, you know, reported side effects such as urinary tract infection, nasopharyngitis. I think they are more or less almost the same across the board, and it's clinically not that significant. So now, what we are most interested in when it comes to mirabegrons is actually hypertension and palpitation. So in this case, you can see that the percentage of hypertension reported in mirabegron 50 milligrams is 43%, mirabegron 100 milligrams is 50%, and toturidine is 42%. Okay. And the other one, which is of interest to us, is of course the QT prolonged interval as well as the cardiac arrhythmia. As you know that this is a adrenergic agonist. So you can see from these studies here, in fact, to our surprise, the toturidine actually have a higher incidence of cardiac arrhythmia as compared to mirabegron 50 and also 100 milligrams. Now, going back to the EAU guidelines 2020, it actually shows that for those patients who have overactive bladder, we can certainly offer antimuscarinic or mirabegron, okay? And of course, these are only advocated for those patients who have failed conservative treatment, means you have advocated the behavioral therapy, pelvic floor exercise, and it really didn't work, then probably you can actually suggest them to actually consider the antimuscarinic or even mirabegron. So this is out in the guidelines. Now, we also have had many studies that have shown that there are patients who have switched from antimuscarinic to mirabegron and actually show us that they have better satisfactory rate, because we know that the antimuscarinic often give us constipation as well as dry mouth as side effect. Constipation may be the same across the board, but dry mouth is significantly lower in mirabegron. Now, this is also some chart to show that the reported incidence of improvement from antimuscarinic to mirabegron. You can see that there are 55.3% of patients reported improved outcomes after a month of switching from antimuscarinic to mirabegron. Now, of course, we are most concerned about patients who are elderly. So there are studies, these studies is pillar studies, that shows that Maravigon show equal efficacy in patients more than 65 years. As you know that antimuscarinic, we sometimes hold back a little bit, giving to those patients who are a little bit elderly because of the cognitive impairment. Now, what about when it comes to Maravigon? Maravigon in these studies have shown that it is pretty safe, and so it actually demonstrated a good efficacy for those patients who are elderly with an overactive bladder symptoms. Now, is there any adverse impact on the cognitive function? So in these studies, the pillar studies, a trial studies of about 3 months, it shows that there was no adverse impact at all. So it's clearly demonstrated in this chart. Okay. Now, the other thing that we are most interested is that, you know, that I would say probably about 80 to 90% of patients who are on antimuscarinic will probably drop out after a year or two. Either they get used to the site, you get used to their lifestyle, or they try to do some form of a lifestyle modification. So now we are most interested to know whether Maravigon also exhibit the same thing. So this is a studies after a span of a year has shown that it actually shows that the time to discontinue the Maravigon as compared to totorudine or other antimuscarinic is a lot longer. That means to say the persistence and adherence to Maravigon is much better as compared to any other antimuscarinic. Now, the other problem with the antimuscarinic is patients with glaucoma. You know, that is an absolute no-no once again. So we want to know whether Maravigon is actually safe enough to be used in this group of patients. Well, the answer is that there are many studies, and this is just one of them, to show that it actually does not raise the intraocular pressure in patients with glaucoma. Again, it's a good news for us, especially treating those patients with the glaucoma issues. Now, what about the tolerability and the effectiveness of Maravigon in children with an overactive bladder? Now, there are many studies, and in fact, there are many trials which are ongoing, trying to, give a pediatric group a chance to use the Maravigon. So at the moment, I believe we have studies conducted in children between 8 to 12 years old. The Maravigon dosage is from 25 milligrams to 50 milligrams, and I think the study is still ongoing, and so far it's been promising. Now, the other questions I'm often being asked is that whether the Maravigon is safe enough to be used in pregnant women or in lactating women. Well, the answer is that there are no studies conducted in pregnant women or even a lactating mother just yet, but we have had studies done in an animal. So they found that for those patients, the lactating animal, Maravigon was actually found in the breast milk. So this is so far that as much as we can tell you. And the other thing, the safety, there's no studies done for pregnant women, as I mentioned to you earlier on, but in animal, it's been shown to be quite safe. So at this moment of time, I think we are still trying to justify the usage of Maravigon in a pregnant woman. So until further information are available at this moment of time, we still hold back a little bit in terms of patients who are pregnant. Now, of course, just like any other medications, we do have some contraindications for the usage of Maravigon. So when we talk about uncontrolled hypertension, now, how do you define the uncontrolled hypertension? Essentially, it's a systolic blood pressure of more than 180 and diastolic of more than 110. So if you have patients of those group, I think it's best to avoid the Maravigon. And of course, for those patients who have renal failure, liver failure, or prolonged QT interval or heart arrhythmias, I think it's best to avoid that. And those patients who are already having issues with emptying the bladder, you do not want to actually make them worse by giving them the Maravigon. And of course, there are some patients who actually develop allergic reactions, just like any other drugs. You know, there are patients who develop reaction towards the Maravigon, so it's best to avoid that. Now, because of the fact that it's actually metabolized with this CYP3A4 and also CYP2D6, there are medications that should not be taken along together with the Maravigon. Those are thiorezazine, which is of course mental illness medications. Itraconazole is antifungal. Ritonavir is for the HIV. Digoxin, haloperidol, and amiodarone, because these are all medications when combined together with Maravigon will have excessive enhanced effects. So it's best to avoid. Now, talking about the pharmacology of overactive bladder, we do have other things such as transdermal oxybutynin, which is again not available in Malaysia. What about the surgical options? Well, the other surgical options is probably the Botox that we frequently talk about. And of course, ultimately, if nothing works, then we have to subject the patient to augmentation cystoplasty and also urinary diversion. So now a little bit about the botulinum toxin. So usually for those patients who have neurogenic overactive bladder, we will give them 200 units. With the idiopathic overactive bladder, we will give them about 100 units. Okay, so it's been recommended for those patients who failed conservative therapy, who failed pharmacological therapy, then we will subject them to use the botulinum toxin. So this is basically considered as a third-line therapy, and the patients must be willing to come back for frequent Botox injection, because the Botox injection only lasts for about 6 months, and these patients must be happy to come back for the injection, because it is not one injection and lasts for life. And of course, when it comes to intravesical Botox, basically it can be done under local anesthesia with a flexible cystoscopy and also general anesthesia with the rigid cystoscopy. So you can see that we inject multiple sites for neurogenic Detrusor overactivity. We use about 200 units. We inject over 30 sites. For patients with the idiopathic neurogenic bladder, we inject 100 units over 20 sites. So this is a standard protocol. So you can see from here that it actually does significantly causes reduction in the incontinence episodes for this group of patients, up to about 3 times reduction, okay, as compared to placebo. Now, for the frequency in maturation, it also reduced up to about 3 times. Now, of course, it actually significantly reduces the daily urgency episode up to about 2.5 times as well. So intravesical Botox, there are patients obviously will develop side effects. So 8 to 9% of patients will have urine retention. Okay, so in most of the studies, it's up to about 6%. So 6% of the patients will have to be counseled on CISC, and ultimately they have to learn how to do it. We always will tell the patient and counsel the patient prior to that they must be willing to do the CISC, after the Botox injection, because sometimes we may not be able to guarantee that they will not go into urine retention. And of course, gross hematuria, these are basically quite transient. And you do have other side effects such as dry mouth, dysphagia, impaired vision, eyelid weakness, arm weakness, leg weakness, and torso weakness. Basically, is the toxicity of the intravesical Botox. Now, a little bit about the surgical treatment, which I know that is not supposed to be a topic that I'm talking about. So I'm just going to run through very quickly. Percutaneous tibial nerve stimulation, basically, we actually do it in a clinic setting. It's only about 12 sessions, and the effect can go up to about 3 years. Each session is about half an hour. We stimulate the posterior tibial nerves, which will, of course, stimulate the sacral arc. Okay, so once the sacral arc is stimulated, the overactive bladder will be dampened down to a normal bladder contractility. Now, we of course have had many studies done to show that it actually works. There are contraindications for those patients using the PTNS, patients with pacemaker, patients who are more prone to bleeding, patients with a nerve damage, and pregnant patients. These are all contraindications. In fact, the PTNS is basically involving just a little tiny acupuncture needle that we actually hit onto the posterior tibial nerve. Okay, and of course we have many studies to show that it's actually efficacious, and it gave a sustained improvement up to about 12 months, and the longest studies that we have acquired is up to about 3 years. Okay, there's no serious adverse events. Now, sacral neuromodulation is basically the last choice, and ultimately is the ultimatum, I would say, because sacral neuromodulation works on 2 extreme ends. It can be used for severe overactive bladder. It also can be used for urinary retention, means non-obstructive retention. Now, it basically consists of an electrical stimulator that we usually will implant it somewhere near the sacral nerves. And the sacral nerves that we are looking at is actually S3. Okay, S3, and sometimes we use the S4. So it interrupts with the abnormal reflex arcs that results in a symptom pattern. It alters the C fibers, and it's very effective in suppressing the Detrusor overactivity. Okay, so now when we put the electrical stimulator in there, usually it lasts a patient for about 5 to 7 years. Now, this is how we do it. We break it into 2 stages. The first stage, we put the battery outside. Now, and then we give a trial of about a week and see whether it works. If it works well, then we will actually decide to put it as a permanent one. That is going to be a stage 2. So stage 1, the patient will have an external battery, as you can see from the picture. Stage 2, the battery will be implanted inside. So after we implant it inside, we don't take it out anymore. And the patient will be given something like a remote control. And if they want to off it, like for example, some patients halfway through, they suddenly get pregnant, we can actually use the remote control just to off it, and the patient can just off it on themselves. So it's pretty simple. All right, so this is actually the second stage. You can see that the wound is just about that. So the efficacy of it, you can see that it actually, for those patients who actually have urge incontinence, 79% of them shows improvements, 45% actually achieve complete dryness. Now, for those patients who have an urgency frequency symptoms, 64% of them show improvement, 31% are able to void normally. Now, for those patients who have urinary retentions, you know that until this time, we still do not have a medication that used to treat the urinary retention. So 77% actually shows improvement in terms of urinary retention. 61% of them actually goes home without a catheter. Okay, so you can see how good it is. Now, the most common therapy related side events will be the pain at the implanted site, the lead migration, infection, technical or device problems, and adverse change in the bowel, and undesirable stimulations or sensations. So most of the time, the patients will feel that there's a little bit of vibrations over the electrical stimulator area. Some contraindications is not intended for patients with mechanical obstructions such as prostate enlargement or benign or cancer, patients less than 16 years old, safety concern in a pregnant woman, once again, or patients with a cardiac pacemaker, or patients with progressive systemic neurological diseases, because they are very unpredictable, because some of them have a known neurological disease, can go from one end, the beginning of the year, to the other end of the year. And of course, other surgical intervention will be augmentation cystoplasty, which we seldom do nowadays for overactive bladder since the introduction of better medications such as merobackron, and of course the Botox injection, and of course Detrusor myomectomy is probably a thing of the past, and nowadays we seldom perform. And towards the end, if all things fails, we will actually divert the urine away from reaching the bladder. So when there is no urine reaching the bladder, there is no Detrusor overactivity. Okay. So now, I think, of course, there are other things such as indwelling catheter, intravesical vaniloid that we use, which is, of course, not an ideal treatment for patients with overactive bladder. And of course, when it comes to newer things, we need to actually find a biomarker to gauge the overactive bladder, and so that we can understand the pathophysiology behind it. Now, functional MRI should also provide an imaging tool to ascertain the role of central nervous system. We know that the overactive bladder is due to the nerve conduction issues. And of course, the sensory signaling from the bladder and urethra has also been studied with various methods. And of course, we need to study more in depth about all this, the nerve conduction problem. Now, advanced technology, gene therapy, stem cell tissue engineering has been studied, but so far we have not seen, unfortunately, a very promising results. So I think I would end my presentation. So as you know, the urologist's favorite shortcut is Control P. So you have to control the P for overactive bladder. Thank you.
Thank you, Mr. Warren. We would like to a short video on merobackron. So after this, we'll show you a short video on merobackron.
A new perspective on overactive bladder, or OAB. A new perspective on overactive bladder, or OAB. Brought to you by Astellas. Symptoms of OAB typically involve sensations of urgency, with or without incontinence, usually accompanied by frequency and nocturia, in the absence of any other underlying pathology. Associated with these symptoms are involuntary contractions of the detrusor muscle, which occur during the urine storage phase of micturition. In many cases, these contractions are non-voiding and do not lead to incontinence. Thanks to decades of research into bladder storage dysfunction, a new theory on OAB management is emerging. This innovative theory focuses on one key function in the bladder: relaxation of the detrusor muscle. The detrusor muscle plays an important role in regulating bladder relaxation and contraction, both of which are driven by autonomic signaling. Throughout the urine storage phase, which accounts for the majority of the micturition cycle, the bladder is relaxed. The bladder is under both parasympathetic and sympathetic control. In the storage phase, which is mediated by the sympathetic nervous system, relaxation and stretching of the detrusor muscle maintain low internal pressure, while the bladder neck and urethra are contracted to prevent leakage of urine. Voiding of urine occurs when the bladder is in the contraction phase, as mediated by the parasympathetic nervous system. In order for the bladder to empty, contraction of the detrusor muscle through M3 muscarinic signaling must occur. This reflex is triggered by the binding of acetylcholine to M3 muscarinic receptors on the surface of the detrusor smooth muscle. In the overactive bladder, the detrusor muscle may involuntarily contract during the storage phase, sometimes resulting in incontinence. One current approach to the treatment of OAB is the use of antimuscarinics, for example, solifenacin, whose mechanism involves blocking the muscarinic 3 receptors, or M3 receptors, leading to inhibition of involuntary detrusor contractions. Complicating this approach, however, is the near ubiquitous expression of M3 receptors throughout the body, notably in the salivary glands, colon, and ciliary smooth muscles of the eyes. For a proportion of patients, use of antimuscarinics can lead to bothersome adverse events like dry mouth, constipation, and blurred vision. In addition, some patients fail to respond to antimuscarinics. Focusing on sympathetic bladder control, recent research has revealed one receptor to be the key modulator of detrusor muscle relaxation, the beta-3 adrenergic receptor, or beta-3AR. The beta-ARs belong to a family of G-protein-coupled receptors that are involved with cellular signaling throughout the body. There are 3 subtypes of beta-AR whose messenger RNA has been detected across a wide range of tissues in humans. Beta-3ARs are highly expressed in the human bladder, where beta-3 accounts for over 95% of the total beta-AR messenger RNA. While present elsewhere in the body, beta-3AR expression has not been found in the salivary glands or ciliary smooth muscles of the eyes. In the bladder, beta-3AR messenger RNA expression has been found in the detrusor muscle as well as in the urothelium. It has been shown that detrusor relaxation is mediated by beta-3AR activation. This reflex commences when noradrenaline is released from sympathetic neurons that innervate the bladder and lower urinary tract. Binding of noradrenaline to the beta-3AR on the surface of the detrusor muscle signals the muscle to relax. This action also determines the interval between successive voidings. Recent research on this natural pathway of bladder relaxation reveals that it is possible to relax the bladder without affecting the magnitude of the voiding reflex or muscle contractility. Furthermore, such signaling may prolong the duration of the storage phase. Mirabegron, a beta-3 adrenoceptor agonist developed for the treatment of OAB, can selectively enhance urine storage by targeting the natural pathway of bladder relaxation. Theoretically, mirabegron has the potential to address the unmet need in OAB patients. This video has been brought to you by Astellas.
Now is the question and answer time. Question to Mr. Warren first, because he's leaving after this. Mr. Warren, there's a few questions. Number one is there's significant association of anticholinergics with poor cognitive impairment and dementia. Would mirabegron be the answer for these patients who have elderly patients who have OAB?
I would say so, because to be honest with you, of course, anticholinergic, we do have the quaternary compounds such as trospium, which of course doesn't cross the blood-brain barrier, equally good. But again, now that we have this mirabegron, I think there are many studies been done for those patients who suffer from Alzheimer's and Parkinsonism, and it's been found to be very effective as well. So I'm hoping that it can actually be recruited into the product insert so that we can use it. But at this moment of time, there are already many off-label uses of meroperidone for those patients.
So I would
and
say,
not just for the not just for the Parkinsonism.
I would just say trospium would be equally as good, right?
Yes, that's right. I mentioned the quaternary compound trospium, and I say that meroperidone would be a good alternative for that.
Okay. Question number 2, you say there is some ECG changes for patients who had on meroperidone. Would preliminary before starting meroperidone, would you do an ECG first? Because our Malaysian patients have multiple medical disorders.
I think the question here is that whether should the patient be identified to have a prolonged QT interval? Should they be put on the meroperidone? My answer is that if the patients were found prior to have this, then I think that we should actually be trying to avoid the usage of meroperidone. So meroperidone, I think most people will be more interested to find out whether it actually causes palpitation, arrhythmia. But in most of the studies, phase 3, it's been shown that it only increased the heartbeat by 1 beat per minute, and the blood pressure also 1 millimeter mercury. So if you were to look at a lot of other studies, such as Scorpio and also Taurus studies, and you can find that, in fact, the anticholinergic actually causes a higher incidence of hypertension and palpitation and also arrhythmia as compared to meroperidone. So for that, I think that we, even though are cautiously aware about this, but at this moment of time, I don't think that any one of us have actually seen patients suffer from a stroke or anything like that because of the meroperidone. But having said that, those patients with hypertension, for example, systolic blood pressure of more than 180, diastolic of 110 and above, I would say that I would definitely try to avoid using a meroperidone.
Okay. I did see also in meroperidone that you allow patient with glaucoma to be started on meroperidone. So, but it was not in the product insert at this moment that you can use for glaucoma patient, especially close angle.
Yeah, that's right. Yeah, you are quite right. So to be honest with you, I think there are many things they are supposed to put it in the product insert, but it's still not there yet, but it's already been used. So if you were to search, you will find out that glaucoma, of course, anticholinergic is not allowed, but meroperidone would be a good alternative. In my own practice, I actually will use it for these 3 group of patients that the anticholinergic will not be not that suitable. Number 1 is the Parkinson disease. Number 2 is the glaucoma. And of course, number 3 is the myasthenia gravis, which again is contraindicated in terms of anticholinergics. Okay.
And another question on Botox. A question asked whether Botox, can it be administered by only the urologist or urogynecologist too can administer Botox?
I think this one you caught me. Well, the answer is that I work in many countries. So, in UK, the urogynecologists are administrating the Botox as well as the urologists. But there are also countries whereby only the urologists are administering, and also there are countries whereby they're both allowed. So in Malaysia, we haven't actually reached a consensus just yet. But more importantly, we need to know that Botox, even though it's simple, but there are a lot of theories behind that. So injecting is not a problem. Managing the complication is a problem, because a lot of us, like for example, in my territory, we usually deal with a lot of neurogenic bladder. Neurogenic bladder, we inject about 200 units, but not forgetting the fact that those neurogenic bladder patients also have some form of a spasticity. So the neurologists and also the rehab physicians are also using the Botox to inject it over the spastic limb. So you have to be aware that the Botox, in 3 months' time, you should not actually exceed about 400 units. So there's a cutoff point for that. So I think we have to work as a team to actually come up with a consensus of whether who can actually give the Botox. Because the theory behind it is more important, how to deal with the Botox toxicity, how to avoid the complication. And if it does happen, for example, some doctors who doesn't know how to inject Botox can literally just tear through the whole bladder. Are you able to handle the repair of the bladder after that?
Okay, I think we should be able to repair. Okay, question to Mr. Warren again. Do you do a post-void residue prior to starting meroperidone?
I will do a post-void residual routinely, whether I'm starting the meroperidone or anticholinergic, because you do not want to tip them over to urinary retention. So that will be a routine for me.
Okay. And questions also regarding Botox. There's a problem voiding dysfunction, which can go up as high as 10%. How long does this voiding dysfunction last, or when will it start after Botox injection?
So you're talking about Botox injection for voiding dysfunction. So first of all, we need
Botox
to ascertain.
Botox injection for OAB. When will we start to, when we counsel patient, when will the Botox, after Botox injection, will they start to have voiding dysfunction? And when they started, how long will it be before the bladder actually return back to normal?
Okay, so for example, if I were to use the urinary retention as one of the extreme example, okay, so Botox usually does not see its effect within 1 or 2 weeks. Most of the time is only after 2 weeks. So when after the injection, the patients will be like normal, apart from a little bit of bleeding and a little bit of urgency and frequency. That is the usual thing. 2 weeks later, when the Botox starts to show its effect, the patient will see the improvement. Whether the Botox is indicated for overactive bladder or even interstitial cystitis, they will start to see the improvement. And it takes at about 3 months, and 6 months just before 6 months, the effect gradually went off. So if you were to ask me, if the patient do develop some form of a urinary retention, yes, it will take up to about 6 months before it can actually win off on its own. Soonest also about 3 to 4 months. So the patient have to be counseled regarding, in literature, it's about 6% risk of catheterization prior to the info for this intrabuccal Botox.
Okay, 6%. The question number, this is a patient who had overactive bladder, partially treated with anticholinergics, the maximum dose, but somehow doesn't work. You need a second treatment. Is there a role for double treatment, and what drug would you use for the second treatment?
Well, if you're talking about the double treatment, you can either go on anticholinergic as well as a marobagram, because it's in our EAU guidelines. Okay, so this is what we call a combination therapy. Now, and also, you also must be aware that there are also other alternatives apart from the oral tablet. You can also use, in other countries, but not in Malaysia, transdermal oxybutynin also can be used together. So this is still a combination of pharmacotherapy.
You mean transdermal oxybutynin together with another anticholinergic, or
that's
transdermal?
Right, that's right.
Oh, I thought you have to be a different group, like anticholinergic and another group.
Not necessarily so. Not necessarily so.
So just change the mode of delivery. Okay, thank you, Mr. Warren.
Exactly.
They are all your questions. I would like to thank the speaker for giving such a good talk. I would like to thank the participant for joining and giving us so much questions. Very, very good question for us. Then I would like to thank OGSM for organizing this webinar series. I hope all the participants benefit from this talk. And I personally think that, like in UK, OAB can be managed in the GP settings, but provided you have to fulfill certain criteria before you start patient on treatment. That all those have our speakers have informed you what are the complications, what are the side effects, what are the contraindications.